Welcome to the deep dive. Today we're taking a deep dive into a medical topic that can feel quite overwhelming. Popliteal artery aneurysms. You might hear them called PAAs.
That's right. And if you or someone you care for has been navigating this, our goal today is really just to give you some clear, understandable information.
Yeah, information straight from the latest expert guidelines so you feel, more empowered in those doctor's appointments.
Exactly. To help you have those informed discussions with your healthcare team, understand what's happening, why certain things are recommended.
Okay, so let's unpack this. PAA. Imagine the main artery behind your knee. Think of it like a strong garden hose, right? Carrying blood down your leg.
Good analogy.
A popliteal artery aneurysm then is when a section of that hose develops a bulge. It balloons out.
hmm And it's actually the most common place for this kind of aneurysm outside of the big ones in your chest or your belly. Accounts for about 70% of these peripheral aneurysms.
70%, that's quite a lot.
It is, and we mostly see them in men, typically in their 60s and 70s.
Okay.
Now, a normal artery there is, maybe 5 to 9 millimeters wide, pretty narrow. But an aneurysm, we generally consider that 15 millimeters or more, sometimes much larger.
15 millimeters, okay. And you might think, like with other aneurysms, the big worry is it bursting, right?
That's what most people assume. But interestingly, with PAAs, the biggest immediate concern isn't usually rupture. It's actually something else.
Oh,
It's that blood clots can form inside that weakened sort of bulging part of the artery.
okay, so like debris inside the hose, going back to that analogy.
Exactly like that. And those clots, they can break off, travel downstream.
And block the blood flow further down to lower leg of the foot.
Precisely. And that can lead to really serious issues. A condition called severe limb ischemia. Ischemia just means blood flow is drastically restricted.
And that sounds serious.
It is. In some acute cases, unfortunately, it can even lead to limb loss. The guidelines mention that happening in about 14% of those really acute situations.
Wow. Okay, so given those risks, how do you find out if you have one? Diagnosis must be key.
Absolutely crucial. And if you are diagnosed with a PAA in one leg, the guidelines strongly recommend screening the other leg too.
Oh, because they often appear in both.
They often do, and screening for an abdominal aortic aneurysm, or AAA, is also recommended. They tend to occur together.
And how is that screening done? Is it complicated?
No, usually it's very straightforward, just a simple ultrasound, non-invasive, no radiation.
Okay, good to know. So let's say an ultrasound finds a PAA. You don't have any symptoms. What happens then? When do doctors decide to, intervene?
That's a really important question. For these asymptomatic PAAs, the ones not causing problems yet, repair is generally recommended if the aneurysm gets to about 20 millimeters in diameter.
20 millimeters. And the main reason is to prevent those clots we talked about.
Exactly, to stop those clots from forming and causing trouble down the line. Now, for some patients, maybe those with other significant health risks, the surgeon might watch it a bit longer, maybe wait until it reaches 30 millimeters. It's a bit nuanced.
Okay. But what if it's smaller, say under 20 millimeters? Is it always just watch and wait?
Not necessarily, even if it's smaller. If tests show there's already some clot inside the aneurysm, or if there are signs the blood flow to the lower leg isn't quite right, repair might still be considered.
Got it. So it's not just size, but also what's happening inside it. What about if someone suddenly does get symptoms, like that severe blockage, the ischemia?
Right, acute limb ischemia, that's an emergency. The urgency really depends on how severe it is. Mild to moderate cases. We might start with clot-busting medications first, try to dissolve the blockage and get blood flowing again.
Okay, try medication first if possible.
If possible, yes. But severe cases where the limb is really threatened, that requires immediate intervention. Surgical repair or endovascular repair to save the limb?
And sadly, sometimes.
Sadly, yes. If the tissue damage is too severe, if the limb is considered non-viable, then amputation is, unfortunately, the necessary step.
Okay, so when intervention is needed, whether it's urgent or planned, what are the main ways to fix the PAA itself?
There are really two main approaches. There's open repair and there's endovascular repair.
Open versus endovascular. Let's break those down. Open repair sounds like traditional surgery.
It is. It involves making an incision, and the surgeon creates a bypass. They basically reroute the blood flow around the aneurysm, often using a piece of healthy vein taken from your own leg, usually the saphenous vein.
Okay, like building a detour around a damaged section of road.
That's a great way to put it. Then there's endovascular repair. This is less invasive.
Less invasive how?
Instead of a large incision, the surgeon typically makes small punctures, usually in the groin, and threads catheters and wires up to the aneurysm. Then they deploy a special tube inside the artery. It's called a stent graft.
A stent graft.
Yeah, think of it like lining the weakened pipe from the inside with a new reinforced lining. It seals off the aneurysm sac.
Ah, okay. So shoring up the existing road from the inside rather than building a detour.
Exactly.
Which one is better? Is there a preferred method?
Well, it depends. Open repair, especially using your own vein for the bypass, generally has better long-term results. The bypass tends to stay open longer,
What?
but it's major surgery. It's tougher on the body. Endovascular repair is significantly less taxing, quicker recovery, less physiological stress. So it's often a really strong option for patients who might have other health issues or maybe a shorter life expectancy who might not tolerate open surgery as well.
So it's really tailored to the individual.
Very much so. The choice involves looking at your overall health, how long the repair needs to last, the specific anatomy of the aneurysm and your blood vessels. Your vascular surgeon will discuss all these pros and cons with you.
That makes sense. And whether you have surgery or maybe you're just monitoring a smaller asymptomatic PAA, what about afterwards? Is follow-up important?
Oh, absolutely vital. Regular follow-up is key. This usually means physical exams, checking the pulses in your feet, measuring ankle blood pressures, and getting regular ultrasounds to check on the repair or monitor the aneurysm if it wasn't operated on.
So keeping a close eye on things.
Yes, vigilance is crucial. It helps catch any potential issues early, whether it's a change in the aneurysm size or a problem with the bypass or stent graft. It ensures your continued well-being.
And I imagine general health stuff matters too.
Definitely. Things like quitting smoking, that's huge for vascular health, controlling blood pressure, managing cholesterol, diabetes if you have it, all these play a really big role in your overall artery health, not just related to the PAA.
Right. You know, understanding all this, it isn't just about knowing a medical term. It feels like it's about feeling more confident when you talk to your doctor, being able to ask the right questions, participate in the decisions.
Absolutely. It really should be a partnership. You understanding these guidelines, the why behind recommendations, helps you be a better advocate for your own health.
Couldn't agree more. So let's leave our listeners with a final thought, something to mull over. How might, knowing that different size PAAs can grow at different speeds, how might that change the conversations you have with your doctor about your specific situation? About how often you need checkups or when intervention might become necessary down the road? What questions does that raise for you?